som.
Tem delay, tem delay.
Uns 25 segundos. Uns 25 segundos, foi, né?
noite a todos.
Mais perto.
Mais perto, pronto. Boa noite a todos, muito prazer. Meu nome é Fred, sou diretor da KTR. Com grande prazer e satisfação, estamos recebendo mais praça. É uma grande satisfação de receber vocês. Deu branco, um minutinho, começar. É? Que avaliação, boa. Começamos do zero. É um prazer receber uma equipe tão qualificada de médicos para uma mesa redonda, onde a gente vai poder mostrar e apresentar todas as novidades, todos os benefícios e toda a tecnologia da criobelação. A iSecure nós da KTR estamos muito confiantes no trabalho que a gente está fazendo aqui no Brasil. O Leandro, como nosso diretor de operações, está trabalhando, acho que conhece um trabalho eficiente, tá? Gostaria de parabenizá-lo pelo trabalho. Gostaria também de agradecer a presença de todos vocês aqui. Eu tenho certeza que vai ser uma noite muito produtiva, muito gratificante e muito construtiva. Eu gostaria de chamar o Dr. Zé Hugo, o nosso mediador, para dar início aos trabalhos. Muito obrigado. Boa noite.
Obrigado, Leandro. Obrigado pelo convite. Um prazer estar aqui com vocês. Primeiro dia também da Onco sobre esse Onco. Começamos com o pé direito. Também obrigado pela presença de vocês no congresso. O congresso só é bom porque está todo mundo lá. Vou mudar aqui para o inglês. Our first speaker, Dr. Franco Orsi, thank you again to be here with us. Okay, it's a pleasure to have you here. For those of you who don't know, Franco Orsi is a legend in interventional radiology with focus in treatment of breast cancer. He's been doing this for 10 years already, or even more, almost.
Not breast, but the high school is more than
10 years. And he's gonna show us a little bit of his work here today. Please, Dr. Orsi, the stage is yours.
Okay, thank you. I mean, I'm very old in the field. You can see by the color of my hair. I mean, started more than 30 years ago doing this job as interventional radiologist in IO. And I'm very glad to be here and very glad to this lecture and sharing the experience in breast cancer with you. That's because since 1994, I was working in the European Institute of Oncology that was founded by Professor Umberto Veronesi. I don't know how many of you really knows this name because I mean Umberto Veronesi is the one who is introduced for the first time quadrantectomy instead of mastectomy. And this is an important milestone in the story of breast cancer treatment. And I'm very, very proud to having worked with him. He passed away 8 years ago nowadays. And I mean, I'm very proud to have working with him because, I mean, he was the one who 30 years ago when he was founding the European Institute of Oncology called me in Rome. I mean, he didn't know me. I mean, he was calling my boss at the time because in his mind, he was just to start a de-escalation in oncology treatment. So in his mind, it was just to reduce any kind of invasiveness in treated cancer. And at that time, I mean, more than 30 years ago, interventional radiology was just vascular. Almost nothing. I mean, the only oncology treatment was chemoembolization with lipoidal stuff. So, may I have? It is not working?
Yeah, I can.
Okay. Okay. Okay.
It has to be this way.
Okay, next one. Okay, that's my disclosures. I want just to let you know the disclosures is including the iScrew and the Umberto Veronesi Foundation that was behind the trial that I was going to share with you. Next one, please. Okay, this is what happened in the last, centuries, more than 1 century. There was Halsted was introduced the mastectomy long time ago, and the invasiveness was intended to be reduced in order to maintain the same outcome by Professor Veronesi. And what we are thinking about cryoablation is that it will be probably the next step for further reduction on invasiveness. And IO will be IO, it is not immuno-oncology, it is interventional oncology. That is the oncological part of interventional radiology. And this is probably what we will see in the next few years. I'm confident that this is what will happen very soon. Next slide, please. Okay, the hospital I'm working with was founded and opened in 1994. Last year we celebrated 30 years of activities in my hospital. And between these 30 years, there were a lot of milestones in the cryoablation for.
Sorry, I have to.
Oh, okay, thank you.
Work.
Oh, good. And yeah, a lot of milestones, and of course, I mean, one of the most important one was in 2014 when the first patient was enrolled in the ICE3, that is the world famous trial that's been done in the United States. I was starting fighting with surgical oncologists in my hospital more or less in 2014, tried to convince them to use cryo for doing cryoablation. But however, we started treating breast cancer with a high intensity focus ultrasound in 2010. And then I will let you the story that is very funny. But however, in 2021, I was able to convince our surgeons just to start to write down the protocol. And in 2024, we were very happy to see the paper that was published by the ICE3 group with revealing the data that were really amazing. Sure? Okay, it works. So I want just to share with you some papers that are behind the idea of our trials. This is probably one of the most important ones because it was the first ablate and resect that's been done in 2016. It was a multi-center trial.
Scusi, dottor Arsi, vuole cambiare?
Okay.
Grazie.
Okay. Multi-center trial, 86 patients was ablated and resected after 28 days. You can see the tumor size was 1.1, 1.2 plus minus 0.3 centimeters, so very small lesions. However, only 92% were successfully ablated when multifocal were excluded. This is a very big mistake because probably the patients were not very well selected at the beginning because they discovered the multifocal. This is after resection, so this is not a good news. However, a patient with tumors up to 1 centimeter was successfully ablated in 100%. Okay, with very important results. This is another important, very important milestone in the management of this disease. This is a paper that was published by the group of my hospital. They demonstrated no significant differences in survival among the patients treated with mastectomy, lumpectomy, lumpectomy plus radiation therapy. But look at these curves. There's a big gap between the patients who were treated with a lumpectomy alone compared to the patients who were treated with lumpectomy plus radiation. So it means that radiation is protective in those patients who the lumpectomy has been done. Then in 2024, we IC trial, 5 years follow-up papers, 19 centers. I think this is not a good element because 19 centers do doing 194 patients means that, roughly speaking, they do no more than 10 patients each one. In terms of learning curve, it's not good enough. However, results are very good. They selected only had two negative patients. The tumor were up to 50 millimeters, and the majority received adjuvant treatment, but not radiation therapy. Results are very amazing. I mean, the cancer-specific survival rate was almost 97%. This is absolutely online with the surgical series. The ipsilateral breast tumor relapse is 4.3% after 5 years. Even this number is not so bad. However, we have very important information regarding the resume to normal activities of patients that after 1 year and a half were at home doing the normal activities. 100% cosmetic satisfaction in 5 years. Another important milestone. This is another paper published by the group of my hospital again. They did this randomized clinical trial comparing Elliot, that is electron intraoperative radiation therapy. That it means that during the lumpectomy, they put the accelerator into the surgical field for doing radiation, avoiding the whole breast irradiation afterwards. And they compared the Elliot with the normal breast radiation, but you can see the difference. The difference was, it was a negative study because Elliot had a 4.2% of relapse after 5 years compared to the 0.5%. Look at this. I3 is 4.3%. That is in line with Elliot, but not absolutely in line with the goal of a theoretical protocol for collaboration. If we want to compete to the section, this is the threshold that we need to reach. And this is the last important paper that was published recently by the group of my hospital. They demonstrated that patients older than 50 years with a small, not aggressive breast cancer could avoid, if the axillary is negative by ultrasound, could avoid the sentinel lymph node resections. So this is important for us because if we want just to pursue our aim to treat those patients without touching the lancet, the blade, we can do the treatment following the data coming from this study. So based on these important papers, we spend a lot of time in make a lot of fine-tuning of this protocol. It was very, very amazing and even very, very complex in terms of selection. The foundational criteria are that patient has to be older than 50 according to the sound. Breast tumor has to be up to 50 millimeters according to I3. Cryo plus radiation therapy according to the Elliot study. Because our target is to be not inferior to 0.5% ipsilateral breast tumor relapse after 5 years. Very challenging. Okay. This is the study. It's a phase 2 to stage monocentric. We are intended to enroll 234 patients in our center. In order to avoid the bias of technical diversity from the institutions, they may affect the results. And the primary endpoint is procedure failure rate and may be assessed according to the MRI. So the secondary endpoint, the assessment quality of life, psychological impact. And look at this, the breast questionnaire is the same that is being proposed to all the patients resected in the last 30 years in our hospital. So we do have a lot of data to be compared with the quality of life. This is something like a randomized clinical trial because we do have tons of questionnaire in this on this topic. Then, of course, cost analysis, MRI predictive value, and the tumor recurrence over the 5 years. Oops. Dead. Okay. Okay, this is the tumor characteristic. As you can see, I mean, we can treat just luminal A and luminal B, all patients to be HER2 negative. That's because HER2 positive is a landmark of more aggressive tumor, and all patients with the HER2 positive has to resect the satellite lymph nodes. Okay, and this is all the characteristics. Then going, okay, through the technique, I can just consider at least 5 different steps. First of all, detecting the target is so important because if you miss the target, you miss the success, of course. Just to be clear, it happens even in the surgical theaters. I mean, it happens that the surgeons may skip the tumor because the tumor is not visible or because it was not very well identified by the clip. Very often it happens that the clip has been dislocated or has been placed in the wrong position. However, we are dealing and we are facing with imaging. So we are mastering in imaging, so we cannot fail on this stage. So we need to prepare the patient. That includes the local anesthesia, planning the treatment. That this means I need to know where to place the needle according to the shape and the volume of the breast, avoiding that the ice ball will go back and will affect the skin surface. Guiding the ablation, of course, we need to master ultrasound and closing the session. It is a very easy procedure. We don't need a very complex and a high-end room for doing that. We need just a table for the patient, a high-end ultrasound machine, and the cryo generator. This is all the tools we need. As you can see here, I'm mentioning also the titanium clip. That's because all our patients place the clip, even if they are not resected, but the clip is important for radiation therapists because they used to do a boost of whole body breast radiation where the clip is located. So detecting the target is one of the most challenging part if you are not so skilled in doing breast ultrasound, as I am. So I have to be honest. I mean, I spent all my life doing kidney ablation, liver ablation, lung ablation, every kind of organs, very complex situations. I never put a probe on the breast. And this is important because it is not an organ. You do not have any landmark. You are just to have a huge experience. I mean, my wife is a sonologist. She spent her life in doing ultrasound every day, 20, 30 patients every day. I don't know how she can do this kind of very boring work. However, I mean, I lost myself in the breast because I mean, without an experienced physicians close to you, you can miss the target. So it's important to have a very close relationship with a sonologist. I mean, a breast radiologist. Of course, it's important to have a high-quality ultrasound probe and machine because it is important because we are dealing with very small lesions. Not only very small lesions, but sometimes after the vacuum biopsy, the lesion is even smaller because we are starting with a lesion up to 50 millimeters, and after the vacuum biopsy, you may have 4, 5 millimeter tumor in the breast. Patient position may change a lot according to the volume and the shape of the breast. So you can imagine that the first breast may have a totally different position on the bed than the second one. And I show you that, of course, usually we not, pardon, usually we don't put the arm like that. That is the normal position where the cynologists used to do the breast ultrasound. We cannot do that because the treatment lasts more than half an hour. No one can stay more than half an hour like that. So you have to think about to find your target with the arms right down. And the anatomy will change a lot. For instance,
Yes.
yeah, it is a movie. Oh,
Yes, movie is working. Let me see.
You go there and
Yes.
yeah. Okay, like in this patient, you can see. I mean, the tumor is located. Oh, okay. Okay, the tumor is located down, so we have just to move the breast and change the position for allow you to work in a better position and in a more ergonomic situation. So we can do like that in order to maintain a sterility. I mean, we can just scrub the skin together with a plastic band, or we can do like that with a bigger band, and we can just change completely the position of the breast. Okay. Treatment planning, because we need just to put the tumor in the center of the ice ball. We need just to consider that is the ice ball will be around, if you're using the 3.4 millimeter needle, the ice ball will be around the 5 to 5.5 centimeter length. So we are just to think about to place the center of the tumor around 2.5 centimeter from the tip, just to be sure that they will be completely overcome by the ice ball. And look at the temperature threshold. I mean, we will be really effective here. We will be killing the tumor here. We don't know what happens on -20. And of course, 0 is like licking an ice cream, so it's nothing for the tumor. So the reason why we need to apply the biggest possible ice ball is because we don't know how big will be the safety margin. So we need to reach the maximum diameter of the ice ball in order to be sure that there will be at least 1 centimeter of -40, at least. Okay, patient preparation is easy because the patient doesn't need general anesthesia, the patient doesn't need specific sedation. Sometimes we use midazolam in those patients who ask for midazolam because we used to talk with the patient during the treatment. The prednisone is suggested because the patient will have edema and inflammation afterwards, so it will reduce the inflammatory reaction after the treatment. Okay, this is just an example of a patient with bilateral tumor, luminal A. She is the mother of my very, very old friend, and she didn't want just to be resected bilaterally. She is outside the trial, and she asked for she is outside the trial just because she has a pacemaker, so she couldn't have MRI. That's the only reason why. And 2 different tumors, but however, both the 2 tumors were luminal A. And this is the day of the treatment. Of course, we start with lidocaine that is injected on the same level of the needle track. The only pain the patient will feel will be just the skin at the beginning. That's it, because I mean the eyes is an anesthetic. Okay, this is the incision, exactly where the injection was, and this is the the clip. So we inserted the clip. You can see inserting the clip may be a little bit tricky because the needle is not very sharp usually, and it's important that the clip will be placed exactly into the tumor. I can tell you, I spent some time looking at my colleagues with a huge experience in diagnostic without any experience in interventions, and they just push the clip, but it is not the right way to do that because it's pulled back. So you have just to go with the needle into the tumor and then pull back the cannula for maintaining the clip inside the tumor. And this is what we want to do afterwards. So we start with the hydrodissection. As you can see, the needle has been already placed into the tumor. You can see the needle on the superficial layer. This is just for the sections. You can see both the two needles are in parallel view. And we can inject through the whole procedures. The suggestion is just to be very close to the skin in order just to avoid to affect the ice ball, because the ice ball will not grow if you are injecting saline very close to the needle. So you have to let the ice ball grow. And this is what usually we achieve. It is 5.2 and 3.7, even more. You can see this grow with groove here, and this is because a vessel was there, and you can see how the heat may compromise the shape of the ice ball. That's very important. That's the reason it's important to achieve, as I told you before, a very low temperature at the needle tip, because very low temperature means that you will be able to maintain a low temperature very far from the needle. And this is a big difference between the two systems. Okay, this is at the end. At the end, we use, okay. We use a glove with the warm water in order to speed up the towing, the last towing effect. And once the needle can be moved, this is important, just maintaining the ice ball very stable, otherwise you can really make a lot of damages on the structures inside if you try to twist the needle that is still grabbing the ice ball. You can do some damages inside the breast. Because once you finish the treatment, the ice ball is still there, they will remain at least for 1 hour. It's important just to maintain at the first minutes this is the ultrasound scan through the gloves. You can see the ice ball is still there. Because you put the patient upside down, the ice ball will go in contact with the skin, and if you send the patient back in the ward, you may have some skin burn with the ice ball that has been left after the treatment. So it's important for the few minutes after the treatment just to maintain a distance with the skin. So other sections usually has to be done on the deep part, firstly, because otherwise once the ice ball is growing, you cannot see what happens behind the ice ball. And then the more superficial one. And this is an example. In these situations, it's important having both the two hydro sections. As you can see here, there's almost no space between the tumor and the deeper layer. This is the muscle. And even in the superficial layer, the skin. So in this situation, we start with the deeper part. Okay, again, this is a clip. Okay. This is the deeper. avoid any gas bubble within the syringe you're using for other sections because it will be detrimental. You will stop the procedures because the hair will affect the ultrasound guidance. And this is the way we do. With a stopcock, with a double-way stopcock, we can just move out the air with the lateral hole, and then we can inject easily. And this is a four-hands technique. You may have your partner that will use it, help you just to do the other sections. As you can see here, this is a deeper one, and this is the superficial one. As you can see, both the two needles are mostly parallel. You can see the clip and both the two needles. You can see when you inject the water, you can just move the tumor far away from the skin. So don't be afraid if the lesion is close to the dermal layer, that is the white layer there, because you can move the tumor out very easily with the needle. And this is the axial view. You can see both the two needles and the clip. And this is what we used to achieve, 4.3, 5.4. This is the MRI before. MRI 3 months later. This is a patient within the trial. And the CT scan, that is the CT that radiotherapists use for the simulation for radiation therapy. You can see the clip within the tumor. And that's it. Thank you. Don't forget that there's a masterclass in Boston, 5 October. Has been organized by the Society of Interventional Oncology from US, and it will be the first masterclass ever organized with this topic. Thank you.
You said after you're done, you take out the needle. You still have to take care because the ice ball is still there, right? You keep the warm pack,
Yeah.
but you still keep injecting saline also?
Yeah.
Yes, really?
Yeah, that's because to be a little bit more safer, because I want just to speed up and to leave the patient going to the ward. That's important because mainly when you have a very small breast, or if the lesion is very close to the skin, because after few seconds, few minutes, all the saline will be reabsorbed, and so you will see the ice ball going back close to the skin surface.
If you want to sit here, if you want to sit there, it's up to you. Let's call our next speaker, doutora Vanessa Sanvido, é mastologista e vice-chefe do Serviço de Mastologia da Unifesp. Por favor, doutora Vanessa. Quer que eu chame ele primeiro? Ok, tá bem. Doutor Afonso Nazário, chefe da Mastologia da Escola de Medicina da Unifesp, por favor.
Escola Paulista de Medicina.
Escola Paulista de Medicina.
Boa noite a todos. Aqui minhas apresentações. Eu sou livre docente lá da mastologia da escola. Desde 2022, em plena pandemia, eu virei imortal. Eu sou titular da Academia Brasileira de Mastologia. E a gente participou do First Trial, que a Vanessa vai detalhar melhor, e também agora começando o Sixth Trial. A Vanessa vai detalhar o nosso primeiro ensaio clínico, que foi um estudo, na verdade, de fase 2, para avaliar a eficácia do método. Ou seja, pacientes com tumores até 2,5 centímetros, sem comprometimento axilar, nas quais o tratamento cirúrgico era o tratamento primário, ou seja, QTNL não entra nesse protocolo, se fazia a COR, né, para confirmar o diagnóstico de carcinoma, a imunistoquímica, o paciente assinava o TCLE, e nós incluímos tumores unifocais até 2,5 centímetros, pela mamografia, pelo ultrassom e pela ressonância. Com esses critérios de inclusão, a gente realizava a crioablação, que lá não aparece, né? E depois, antes da cirurgia, que era feita 2 a 4 semanas após o procedimento da crioablação da mama, repetíamos os exames de imagem, porque um dos nossos objetivos é ver qual que é o que dá maior valor preditivo para avaliar a resposta patológica completa. E depois operávamos a paciente. Esse estudo ensejou esse novo que vai estar se iniciando agora, começou a ter umas 3, 4 semanas, que a Vanessa vai detalhar melhor, que é o SIX Trial. Esse é um estudo de fase 3. Vocês viram que nos estudos anteriores se fazia a crioblação e segue a paciente para ver a recorrência, a sobrevida. Esse não, esse é fase 3 randomizado. Vai comparar crioblação cabeça a cabeça com tratamento convencional, que é a cirurgia. Em geral, uma cirurgia conservadora. Então, pacientes, até aqui a gente mudou um pouquinho o critério, até 2 centímetros, porque no estudo anterior a gente viu que esse limite de 2 centímetros é mais seguro para ter uma resposta patológica completa, sem comprometimento axilar, foco único, obviamente visível ultrassom, e cujo tratamento primário não seria nem quimioterapia, seria cirurgia mesmo. Um braço de pacientes, que vão ser mais de 350 pacientes, vai ser feita a crioblação, outro braço, a cirurgia. É um estudo multicêntrico aqui no nosso estado de São Paulo. O tratamento depois, a posteriori da cirurgia, o adjuvante, preferencialmente radioterapia, exceto aquelas pacientes muito idosas, cheias de comorbidades, que a gente nem indicaria radioterapia, mas preferencialmente quando a gente faz uma cirurgia conservadora, estou voltando as costas aqui para vocês, a gente faz a radioterapia. E preferencialmente a radioterapia ultra hipofracionada de 5 dias. Por isso que o estudo chama SIX Trial. Tentar tratar o câncer de mama inicial em 6 dias. E depois o tratamento sistêmico, que em geral vai ser a endocrinoterapia. Então, eu vou mostrar aqui um caso clínico prático de uma paciente que se encaixa nesses critérios. Uma paciente idosa de 80 anos, ela se referiu um nódulo na mama direita há 20 dias, ela já tinha feito o agulhamento na mama esquerda em 2002, que tinha dado hiperplasia lobular atípica do que estava típica, tomou tamoxifeno até 2007 como quimioprevenção, e estava fazendo segmento até 2016, quando perdeu o segmento, depois veio a pandemia, aí que foi mais difícil ainda seguir essa paciente. Ela tinha de interessante de história familiar um tio materno, homem, com câncer de mama. Tinha também uma sobrinha com linfoma aos 33 anos e 2 tios maternos com câncer de intestino, era uma secundípara, um parto, um aborto. No exame mamário, realmente tinha aquele nódulo que ela referia na mama direita, quadrante superomedial, 2,5 centímetros, com axila negativa. Então, se enquadrava no estudo FIRST, que era tumor até 2,5 com axila negativa. O ultrassom na mamografia mostrava só uma simetria naquele quadrante, e o ultrassom mostrava um nódulo angulado, Berrados 4, 2,5 centímetros naquela topografia, quadrante superomedial direito. A COR mostrou um carcinoma lobular invasivo, luminal. Aqui ficou na dúvida se era luminal A ou B, porque o HER2 era 2 cruzes, mas o FISH deu negativo. Então era luminal A mesmo. No nosso protocolo, a gente sempre tentava fazer a ressonância, exceto se tivesse algum marca-passo, ou a paciente tivesse alguma contraindicação para fazer a ressonância, e constatou aquele nó na mesma topografia um pouquinho menor, 18 milímetros, ou seja, se encaixava perfeitamente no nosso protocolo. Propusemos a crioablação, e como é um estudo fase 2 para avaliar a eficácia do método, a gente a posteriori fez a cirurgia, que aqui foi um SNOL. Aqui o nosso Luiz se preparando para o procedimento, o nódulo da paciente. A gente fala que o ultrassom é operador dependente. A crioablação é ainda mais operador dependente. Isso precisa ser, a professora Orso destacou aspectos técnicos, então a gente vai queimar esse método no tratamento. Então precisa ser, a ineficácia do método vai depender da expertise do radiologista intervencionista. Então, localizamos o nódulo, a inserção do clipe dentro do tumor, o procedimento da crioblação, formando aquela esfera de gelo, né, o ice ball, a temperatura aqui em 3 minutos, chegando a baixíssimas temperaturas, ali a bola de gelo se formando. A mamografia pós-crioblação, antes e depois, realmente não é um método bom para controle. Se tiver uma área de assimetria, de densidade, o clipe lá no interior. Ultrassom também não é um bom método para avaliar a eficácia do método. Parece que o tumor persiste, né? O clipezinho lá no meio. E o melhor método realmente para avaliar se aquele método foi eficaz ou não é a ressonância. Vocês estão vendo aqui a esfera de gelo. Isso aqui é antes do tratamento cirúrgico dessa paciente. E o espécie da peça cirúrgica. A área que tinha o tumor totalmente necrosado, uma necrose de coagulação, fica com esse aspecto vinhoso, friável. Por isso que a importância é o clipe no interior, para saber exatamente onde estava o tumor, para ser totalmente ressecada com margem aquela região. O anatopatológico só tinha necrose de coagulação, esteatonecrose e anatopatológico, a ausência de neoplasia. E o sentinela, que a gente fez o sentinela nessa paciente, poderia até não ter sido feito com essa paciente em 2022, 2023. Veio negativa. O estadiamento, acho que em função da crioblação, vai ter que mudar, porque não está previsto no estadiamento crioblação, né? Porque, por exemplo, seria um PT0, PN0. Mas, na verdade, como a gente fez um tratamento pré-cirúrgico, seria YPT0, PN0. Né? Mas isso ainda não está escrito ainda no estadiamento do câncer de mama. Esse método é muito novo nas ferramentas terapêuticas que a gente tem hoje. Depois a paciente recebeu o tratamento sistêmico e terapia. A radioterapia a gente fez em 5 dias. Casa muito bem com esse ensaio clínico que a gente vai começar, de tratar o câncer de mama em 6 dias, o 6 trial. Não foi feito boost aqui, só a radioterapia da mama mesmo. Em função da paciente ter essa história familiar de um tio materno, se sugere fazer o painel genético, que não teria muito benefício para a paciente, mas para os seus parentes sim. E realmente a paciente fez o painel genético, mas felizmente era negativo. Obrigado.
Agora sim, doutora Vanessa. Depois temos o Dallas Azevedo.
Obrigada.
Boa noite a todos. I will try to speak my presentation in English because the Dr. Orsi, but I will try. But my sorry. No. Sorry. I now have a conflict of interest, and now Dr. Orsi speak about this study, but nowadays there are some studying in literature about correlation for breast cancer. The some important study is the ICE3, of course. The results were very important because it's I change the point the recurrence because for me it's important 3.5% of recurrence in 5 years old. But this study is a big problem because not all patients perform the radiotherapy. It's a controversial point the ICE3. And other going study now will answer this question. This is our first study. freeze breast cancer in Brazil, a before-after study. Dr. Nazario said it's a phase 2 study. And this is study design. Dr. Afonso said in Portuguese, but you resume the tumor up to 2.5 centimeters inclusion. All patients perform coagulation followed by surgery. It's necessary coagulation and surgery, and mammography, ultrasound, and the MRI. The object of the study to assess the effectiveness of the coagulation, and the protocol to cycle 6 minutes for 4 minutes, not 10 for 10, you said. And the tumor, it's a unifocal invasive breast cancer. Lesion visualized on ultrasound, and surgery indicated as the first treatment option. It's a clinical case. You can see the small tumor here. Small here. It's a luminal A. It's a perfect tumor to treat with coagulation. The MRI, you can see the MRI, unifocal breast cancer. It's perfect to selection coagulation to treat this tumor because it's small, it's unifocal, and is I will presentation the tumor until 1.5 centimeters, and I believe that this tumor, the coagulation is the best treatment for the situation, the similar this case. It's during the procedure I use the ultrasound. It's a tumor, and I use the clip too, because the first study, all patients perform resection, but it's important you need make sure the resection is correct. So you use the clip, and the second study I use the clip too. It's an ice ball, the final, the procedure. The same in the last class, 5 centimeters the ice ball. It's a big ice ball. And this case you use argon. It's the first study, it's on argon, not nitrogen, but you use to cycle 6 minutes freezing and 4 minutes of tau to cycle again. MRI post-coagulation, the tumor disappeared. You can see only the big ice ball. Again, this image, and this image too. Tumor not identified anymore. And you compare pre and post coagulation. The tumor is not tumor, only ice ball. Mammography and the ultrasound, it's not very good exam to compare. You have effectiveness of coagulation, but you perform 3 exams, mammography, ultrasound, and MRI, but MRI is the best exam for this. The surgery, it's not damage of skin, it's important, and the surgery after this case, no residual tumor was found. So the coagulation is very effective. The results of the first study, we finished this study with 48 cases, and the complete ablation rate is approximately 19%. It's a big problem because I include 2.5 centimeters the tumor. It's not very good size to include. But when you evaluate, we evaluate the without invasive lesion, it's approximately 98%. It's a very good results. And when you MRI identify tumor up to 2.0 centimeter, the accuracy is very, very high because it's approximately 97% or 100%. This is very, very incredible, but this is without invasive lesion, and the 97% it's without or CDS. Benefits of collaboration is many benefits. For example, the procedure is performed outpatients, not necessarily hospital, no necessary anesthesia, only local anesthesia, of course. It's a procedure minimally invasive, short procedure time, and the patient quickly return to daily activities. One day, the procedure is very, very good for the patients. Is the image for this procedure in one video. The IC ball involved all tumor. It's the ultrasound. You can see. The IC ball closes the skin. Não dá pra ver? No, Mr. Oh, you can see the ice ball and the skin is near, and I introduce height section too, because this skin is very, very near the ice ball. And when they finished the first study, the Dr. Orsi said, could the sentinel lymph node biopsy be omitted because the sound trial is publication? If surgery is not performed, is radiotherapy still mandatory? I believe that yes, and the IC3 not necessary, because our team start this new study. Is Crystal 6 coagulation for small tumor as local treatment, and this started this year. It's the new design. For example, this study 6 trial, I include only tumor up to 2 centimeters, and it's a randomization, coagulation versus red surgery and sentinel lymph nodes. The sound is included this design because it's not, I believe that the sentinel lymph nodes possible be omitted, and is followed by all patients. We perform 5 fraction of red therapy. The outcomes, local recurrence, cost minimization, overall survival, disease-free survival, circulation tumor cells, patient satisfaction, and quality of life. I will follow up by patients for 5 years. And the conclusion, coagulation emerges as a promising alternative to surgery to patients with early breast cancer. 100% efficacy in tumor up to 2 centimeters, not only 2 centimeters. MRI plays a crucial role in planning the coagulation. In the future clinical trials will be exception to consolidate coagulation as a treatment option in tumor up to 2 centimeters. And I believe, I believe that the the freezing may be the future of early stage breast cancer treatment. I believe that tumor until 2 centimeters, the freezing is the biggest, the better treatments for these patients. Thank you.
Tem que pegar a caixinha.
Para fechar nossa noite, Dr. Leonardo Azevedo. O Dr. Leonardo é médico radiologista intervencionista do Rio de Janeiro, da empresa Gávea Rad. Prazer, Léo.
Obrigado, Zé. Boa noite a todos. I'll speak in English as well in respect of Franco Orsi. So I will be very quick. I know everybody's tired after a long day of Congress, so I will just present our first case in Rio. We are in the beginning of our experience. We just have 3 cases right now, but we are, and I will show our first case. I have no disclosure for this presentation. So it's a case from a woman, 89 years old, and she has just arterial hypertension and diabetes, and she was very active and independent, and her mammography showed an isodense oval and obscured nodule in the middle third of the middle quadrant of the right breast. And the ultrasound showed the presence of a irregular speculated vertical nodule with posterior acoustic shadowing located at the junction of the upper quadrants and measuring 1.5 at this time. And she had a biopsy in January 2024, which was infiltrating ductal carcinoma, histologic grade 2. And it was a luminal way, which is the tumor that we can treat, so hormone positive and HER2 negative with a KI 675%. And she was with anastrozole 1 milligram day since January 2024. And we discussed this case, and the oncologist called me if it was possible to do any treatment because she was quite old, and the surgeon doesn't want to treat this patient with surgery. And we decided to do cryo. And this is the case, and the lesion was it was smaller than the first exam. It was just 8 millimeters, so the perfect case for the first case. And as Franco said, it's important to have a breast radiologist, and so it was the first case, so I asked for 3 breast radiologists to stay with us. So it was very nice, and this collaboration, and this is the case. It's a video. It's a very easy procedure, so you have to plan, and you have to see the nodule. If you do breast procedures or any percutaneous procedure, it's not a difficult case, but you have to select well the patient. That's the most important thing. Okay, this is the ice ball, as you have already saw, and this is the spinal needle, 22 needle. We inject saline, and this is the ice ball. And it's very important during the thawing case because we do the freezing phase, and the thawing phase you can think I will relax and I will not see the ice ball, but you have to still look the ice ball because it can increase near the skin and cause a skin burn. So you have to keep looking the ice ball for all the procedure, doing all the procedure. And it was a very fast procedure, 40 minutes, and she asked for a light sedation. We don't have to have a light sedation because it doesn't the patient doesn't have pain, but the patient is very afraid from needles, so she asked for a light sedation, and he returned for the normal activities very, very fast. This is the team that was there with us. And the first ultrasonography, the lesion was bigger, it's normal. And we start with the ultrasound. It's a heterogeneous lesion image, so it's normal like this, and it becomes smaller and more homogeneous with time. But ultrasound and mammography is not the best kind of image to follow this patient. And she will do a MRI this week, and we ask for a MRI. For sure, the MRI is the best image to follow this patient with contrast. So the lesion is more homogeneous than the last ultrasound. And it can calcify with the time. Okay. And she recorded a video. It was very nice. She's a very nice old lady. And spontaneously, she asked to record a video to show the technique for other patients that needs this technique. And she's very happy without any symptom. And that's it. Thank you.
So I think we can open for quick questions. If anyone.
Leonardo. Cadê o Leonardo? Eu queria fazer alguma pergunta. Sim, como você falou, tem que ter um critério de inclusão bom para... eu sou mastologista, eu sou cirurgião. Essa paciente eu nem pensaria em operar, porque ela tem 88 anos. Se você botar a expectativa de vida dela é baixa, então talvez mantendo a anastrozol por bastante tempo, você ia controlar essa doença sem necessidade nem de cirurgia, nem de crioblação. Tá? E a segunda coisa, esse é um método original, inovador. Essa paciente teve TSLE, comissão de ética, porque a gente está falando tudo aqui nos nossos estudos que a gente apresentou sobre protocolo. Esse caso, vamos discutir em grupo, tal, e indicar. Mas e o CEP em relação a isso? Foi pensado nisso?
A primeira pergunta que não era indicado, eu não entendi bem porque, mas por conta da redução do tamanho. Sim, mas o que é mínimo para vocês? Entendo, mas é por conta do tamanho? Sim. Uhum. Se tivesse 1 centímetro, o senhor acha que teria indicação? Mas qual é o... cirúrgico, né? Mas a maioria o I3, por exemplo, não precisa de cirurgia necessariamente depois, né? Mas eu não entendi o...
Não, é que é uma paciente de idade elevada, que eu nem, como mastologista, nem proporia cirurgia. Eu só faria endocrinoterapia exclusiva e se a doença progredisse, eu interviria. Você entendeu?
Entendi, mas essa foi a indicação da CRIO, né? Ela não poder ser operada, né?
Tudo bem. Mas acho que nem crio, nem cirurgia esse caso precisaria. Já que ela tem tanta morbidade que não tolera uma cirurgia, né? Você poderia só seguir essa paciente com hormonioterapia, você entendeu?
Ela não tinha...
Em função de você... Um caso desse, precisava ter uma avaliação oncogeriátrica. Essa paciente tem uma expectativa de vida de 3 anos. Então, nem faço procedimento nenhum, só faço o tratamento clínico.
Se ela tivesse 65 anos, você acha que teria?
Não, estou discutindo esse caso que você
Não, estou sugerindo. Mas o senhor tem algum dado na literatura de benefício de sobrevida global para um luminal A com uma paciente de 60 anos?
Tem, opa.
65 anos.
Essas pacientes recidivam tardiamente, né? Não tão precoce.
Sobrevida global.
Tem. Agora, uma paciente muito idosa, que não tem uma expectativa de vida muito grande, nós em tumor boards, nem indicamos só tratamento paliativo assim e controla para não haver progressão.
Mas é que eu acho que você passou rápido no início, mas ela tinha um estado geral excelente. Ela não tinha grande comorbidade e uma expectativa de vida boa. Ela é uma... Não, realmente, talvez tenha passado rápido. mas é uma pessoa, uma paciente que pode chegar aos 100 anos. É,
Sim.
É isso que eu estou falando. Se a gente avalia, e tem hoje modelos para avaliar a expectativa de vida. Né? Se tem uma expectativa de vida acima de 5 anos, aí sim vale a pena. Então, é que não foi apresentado isso, né?
Eu coloquei PS0 ativa e independente.
Então, mas tem modelos mais sofisticados para avaliar a expectativa de vida.
Certo.
Ok.
E sobre o TCLE, isso é uma ótima discussão. Se esses procedimentos podem ser feitos fora de um protocolo de pesquisa, acho que a discussão é ótima. Teve totalmente um TCLE, teve uma discussão multidisciplinar, não teve comitê de ética porque não está num registro, está num registro, mas o projeto de pesquisa precisa passar numa plataforma Brasil, etc. Não é o caso. Ela não teve nenhuma cobrança, etc., de nada, mas foi um termo de consentimento, então é isso. Mas não está no protocolo de pesquisa, está no protocolo de registro nosso. Mas a discussão é boa, acho que faz parte também.
I think I understood the questions, and you're right. This is just for clinical and biological point of view. You have to consider the psychological point of view. I mean, I met a lot of patients. They wanted to be cured because they had tongue cancer. It's very complex to convince them just to stay with the hormone therapy and stop. That's because very usually, I mean, patients have the perceptions that, I mean, we are in a surgical-centric world. Everyone thinking about the surgeons will save your life. So the majority of those patients want to be resected, even if they are 90. I mean, I met a lot of them. They want just to move the tumor out. That's it. They don't trust in something like hormone therapy or something like, because in their mind the perception is there's something solid in their breast. They want to take out. So it is very complex to convince to avoid resections and to do cryoablation. And in my experience, in the experience of my hospital, because even my hospital, they have a couple of trials, try to treat those patients, elderly patients, just with hormone therapy. The majority refuse to receive hormone therapy alone. They want just to be treated, to have something. Even if they are 90 and they will never die for a luminal A with a key 67 of 5%, of course. But however, they still require something. There's sort of psychological, it's a mindset. So I agree with you, but very often they want just to be treated.
Orson, I have a question with you about the radiotherapy follow coagulation. What do you believe? It's necessary 5 fraction? You use what?
We
what
use
your opinion?
hyperfractionated. We use 15 because five section is related to a bad cosmetic result.
Okay.
So that's the reason why we choose them for hyperfractionated. So 15 fractions rather than 5, just because the cosmetic results are a little bit worse.
Okay. I will think about the small time. It's possible to treat more patients about this because my 5 is fraction. Okay.
Yeah.
Thank you.
In our experience, we made a meta-analysis, compare ultra hyperfractionate radiotherapy versus, there are 3 radiotherapies here, conventional radiotherapy. In fact, the cosmetic aspect is better with hypofractionate. Okay, Bruna? We have another, in this meta-analysis that we published,
Yep.
the cosmetic aspect is better with ultra hypofractionate radiotherapy.
I'm not an expert. I'm not a therapist. So I mean, we spend a lot of time with our radiation therapists, and they want just to push for a hyperfractionated, and we are fighting with a lot of other radiation therapists outside our hospital because sometimes we accept patients coming from abroad our centers. So we send the patient to have radiation therapy elsewhere. And we are, not me, I mean, our radiation therapists are fighting with them because they push for hyperfractionated, because results coming from some papers published by Japanese people, they do a very complex cosmetic check every 6 months, and they found retractions in the patient. I'm not an expert, so I mean, I will ask again our radiation therapist. But we spend a lot of time to decide, even, I mean, for us it will be much better 5 fractions than 15 in terms of logistics, but we choose 15 just because the cosmetic results. I cannot say more than this.
We choose 5 days because the cosmetic aspect is very, very nice with 5. So, but
Don't know.
So thank you so much, Dr. Orsi and all the speakers. Obrigado, pessoal. A gente vai encerrar aqui a nossa parte para a gente poder comer, tá bem?
Ladies and gentlemen, there was a pleasure having you here. This is an honor for us having all of you for this amazing discussion, as well as I think this enhances the whole work and makes closer interventional radiology and mastology, which is one of our goals here, as we always work with multi, how do I say that? Multidisciplinary. So enjoy the night, enjoy your meal, and thanks again.